people learn by observing behaviors in clinical education that they then replicate, and that kind of, if they're not particularly beneficial or respectful, they kind of get perpetuated in that way. So we also find that how people learn is affected by personal, behavioral, and environmental factors. And when you're talking about the environment where people are laboring and giving birth, there are a lot of moving parts, and there's a lot of change over the course of time. So my research question was about respectful maternity care, beginning with an understanding of this consent process, and that consent is not a signature on a form. Consent is an ongoing, unfolding process, and that people have the right to withdraw consent, and they have the right to consent to one thing at a time. So if you come in and you sign a consent form, it doesn't mean that people can do whatever they want to your body. So that was kind of the beginning place. And then to acknowledge that there's a lot of complexity around decision-making, where every time you perform a procedure or an intervention, it could change the outcome. It can change the way the labor unfolds. It could change the physiology of the person in labor or of the fetus or newborn. So again, what I found in the literature was that formal curricula in this area are lacking in both medical and midwifery programs. And I chose to explore whether, when I had to condense everything, whether a short interactive intervention would improve self-efficacy in the practice of shared decision-making. So what is shared decision-making? This is a formal process with many moving parts. It is considered a pillar of quality by both national and international policymakers and stakeholders, including the Institute of Medicine and the World Health Organization, and the American College of Obstetricians and Gynecologists, the American College of Nurse Midwives, both have extensive opinion pieces and recommendations about the importance of having this be an integral part of care. So then I came across this concept of equipoise. So the goal when you're talking about equipoise is to reach a state where the outcomes are likely to be equal, and the way that you get to the decision is entirely preference sensitive. And that is a really hard thing to do in the perinatal care cycle. All right, so when we think about childbirth just in and of itself, it does have the potential to be transformational or traumatic or anything in between, but it's never mundane. So this is a big deal that happens in the course of someone's life, and research has shown that, that birth planning during pregnancy is ideal when there are developing relationships with care providers and there's continuity of care over time. And that is something that really just doesn't exist easily in the systems of care as they are right now in our country anyway. So you really have this kind of the large public hospitals, you have large groups, you have corporations that have taken over smaller practices where everything kind of becomes more cookie cutter. So the possibility for someone to even see the same provider several times over the course of prenatal care has gotten smaller and smaller. And so shared decision making is hard to carry on as a thread unless it's really clearly practiced and documented. It promotes an active discussion process that contributes to enhanced relationship building when that's a possibility, and enhances autonomy in a way that doesn't set somebody who's pregnant against their newborn or their fetus or newborn. All right, so when situating my research in the literature, I found a number of similar studies that were performed in a variety of populations. None of these included midwives. And while these study sample sizes varied, you can see that they're pretty small, and that each one of them did have a longer time period, and they also measured self-efficacy at more than one time point. So in my intervention, it was very brief, so it was a pre and post test within that same day. These all had follow-up to look at whether the self-efficacy continued over time. Okay, for my study, the IRB approval was through Thomas Jefferson University in Philadelphia. That's where I was a student for my doctorate in midwifery. What I did was I adapted an existing self-efficacy instrument where usually that instrument was used for patients to measure their own self-efficacy for something where they have learned a new skill, particularly around things like self-care for diabetes. And in this case, we basically adapted it so that it was about provider self-efficacy. And I only found one really big, excellent study about provider self-efficacy that was fascinating. There wasn't a whole lot about that that was accessible in the literature at the time that I did my review. I ended up with 18 items that were derived from an existing validated model for shared decision-making. And the analysis was for the whole group, and then I broke it down into the midwives and the midwifery students to see if there was any difference in those two groups. And what I developed was a 45-minute presentation about collaborative decision-making models, where I talked about these are the existing models, and I talked about the literature. And then the participants broke up into small groups, and each group was given a case to work on. And they had a period of time to work interactively around that case. And then we got back together as a large group, and each group presented its efforts. And the topics were someone declining a cesarean section for a breech presentation at term, planning a vaginal birth following a prior cesarean section, and a client who had a prior traumatic birth after an induction of labor declining a routine induction because she was past her due date. So those were the topics. This is the sample. There was diversity in terms of the credentials and the work sites. There wasn't so much personal diversity because of where we were and the kind of events that people were coming to. 6 of the midwives participated, did hold more than one credential, and 12 of them worked at multiple sites. And this was the age, race, and ethnicity breakdown and the educational background breakdown. We had 71 total participants in 6 presentations in 3 different states. So I did some traveling for this. It was fun. We were in Massachusetts, Pennsylvania, and New York. And one of the cohorts was students here at Downstate. So for my results, this was not the surprising part. We basically saw not a significant difference between the midwives and the midwifery students. We didn't see a significant change in kind of your basic non-interactive skills, like when somebody chooses to decline care that's offered, how do you document that? That didn't really change very much. And there were no changes in skills that are kind of considered the hallmarks of midwifery, and you see them here: establishing rapport, eliciting your client's concerns, engaging them in care planning to the extent that they want to be involved, making empathetic statements, and conveying empathy non-verbally. So this is pretty much midwifery in a nutshell. The fascinating thing was that there was significant change in skills that have a high impact on decision making. They're sort of the more meaty kinds of skills, and the ones that can really, I think in my opinion, are more likely to change outcomes. So we have providing unbiased education about assessments and related care options was one example of that. And that has the potential to make a really big difference. This is the skills where a difference was found. These are the 12. And you can see that they are the kinds of skills that require a little bit of time and attention and a lot more listening than speaking. Really being, the panel talked about the therapeutic presence of self as being a really, really significant feature of quality care. And I would say that that is what's kind of represented here by these skills. And then finally, there were some limitations to talk about. There were a couple of problems with the design of the demographic survey, and that led to some confusion and some incomplete data collection on the demographics. Also, because the PI was known to some of the participants, we can't eliminate the possibility of response bias. I certainly tried to avoid that, but you don't know if it's an issue and how people respond to these things. Also, based on the data and the qualitative evaluations that were given, where there were open-ended text boxes for statements about their experiences, the introduction of concepts and frameworks and this experiential group process did appear to be effective. I would say that in the future, programs like this would benefit from being longer and having more, and potentially interdisciplinary or interprofessional. That was kind of my dream. I think that would be amazing. I also think it would be helpful to continue to evaluate at more distant time points, whether people, because it's a perceived self-efficacy. They haven't actually gone out and practiced it and then come back and said, yes, I can safely say that I have continued to have improved self-efficacy. And in terms of implications, in the qualitative analysis, there were several participants who reported that they were surprised that there was sort of a patriarchal tone in their small groups, and they realized how much work people have to do about developing communication skills that are more open-ended and allow for different points of view. That was kind of interesting. And it further reinforces the impact of willingness and adapting to the tone of usual care. We really need to listen to ourselves in the way that we're speaking to people. My students will definitely recognize that I'm a person who says that when you're providing care, you should not make self-referential statements because the care is about them, not about you. So you would never say, take a breath for me or give me a push, because it's not about you. So that kind of trauma-informed way of speaking is something that is a skill set that we can learn and adapt and bring into our care as a pillar of quality. So I would say that education and innovations in midwifery can impact other professions, and that's because midwives work with everybody on the team. So if we are modeling these kinds of behaviors and this kind of communication, it is something that other people will notice, and if it is respectful care, then perhaps other people who didn't receive that kind of training or part of their education can learn from the modeling that the midwives can do. So this is particularly true in clinical settings, and that was my project. So thanks for your attention.